a side event to the 30th session of the UN Commission on Crime Prevention and Criminal Justice. This event will address one of the important topics of the day, COVID-19 in prisons, vaccinations and responses. The event was organized by the World Health Organization Regional Office of Europe, UNODC, and Penal Reform International. My name is Luciana Paul. I work in the Centro de Estudios Legales y Sociales in Argentina, and I will be moderating the event. Just some comments on the housekeeping. You will see in the lower right hand of your screen 3 dots where you will find there's interpretation in English and Russian, so you can choose your preference. We have a lot of participants today. Fortunately, I beg you to have your mic silenced the whole time unless you are speaking. We will have a very tight schedule, so we welcome for you your interventions or questions in the chat. Speakers will try to address them during the talk, and if it is not time enough to do it, we will follow up with you, so please don't hesitate to send your comments or questions. Note that these sessions will be recorded for reporting purposes, so have that in mind. We will start now with some opening remarks. We will start first with Dr. Nino Berzulli, Divisional Director of Country Health Programs, WHO Regional Office for Europe. Dr. Berzulli, you have the floor.
Thank you very much, Luciana, and good afternoon, dear colleagues. On behalf of the WHO Regional Office for Europe, I would like to welcome you all to this side event of the 30th regular session of the Commission on Narcotic Drugs and the Commission on Crime Prevention and Criminal Justice on COVID-19 in prisons. And the side event is jointly organized by the WHO Europe, UN Office on Drugs and Crime, and Penal Reform International, and stresses the importance of COVID-19 vaccination and leaving no one behind in our fight against the COVID-19 pandemic. And I would like to thank our partner co-convener organizations. I would like to thank Andres Figuerotti and Olivia Rowe for collaboration on this very important aspect and other pressing issues related to prison health. There are over 11 million people in detention globally and 1.5 million just in the European region. And the fundamental health needs of people living in prisons are not adequately met. And this, of course, is raising concerns about the equity, about social cohesion, and the inclusiveness. Health and access to the health services is a human right that has been addressed in the United Nations Standard Minimum Rules for the Treatment of Prisoners, also known as the Nelson Mandela Rules, adopted in 1957 and updated in 2015. With emergence of the COVID-19 pandemics, the deficiencies in prisons' healthcare systems have been highlighted, resulting in outbreak experienced in various countries. And this pandemic has served to highlight the need to strengthen the health leadership and the health systems at all levels and to put in place the appropriate social and economic frameworks that leave no one behind. It is precisely these considerations that are driving the WHO European program of work, which was adopted by all 53 member states, and which has 2 fundamental principles: to achieve upward convergence in health and the health system's performance across the region, and to strengthen the societal trust in health authorities. COVID-19 outbreak brought opportunities to show the importance of integrating prison health and information systems into the wider public health arena. And prison health is increasingly important public health matter, and only by leaving no one behind can we assure the meeting the bold targets of making 1 billion more people benefiting from universal health coverage, 1 million people better protected from health emergencies, and 1 billion more people enjoying better health and their well-being, as it is announced in the WHO General Program of Work GPW 30. This event today will serve as a platform to announce the launch of the new advocacy brief issued by the 3 organizations calling for the inclusion of people living and working in prisons in national COVID-19 vaccination plans. People in detention facilities should be included in the national COVID-19 vaccination plans aligned to the age groups covered in the region to characteristics of vaccine used. And this is very important to ensure equitable access to all population groups in the country and controlling the disease. This brief also will highlight the enhanced risk of congregate living enhanced by several environmental factors, including overcrowding, water, sanitation, nutritional status, physical inactivity, inaccessibility to fresh air, and many others. Offering the same healthcare of that in the community for people living in prisons is not easy, but it requires political will, allocation of resources, governance frameworks, training, and education. WHO defends health as a human right. Health services must be accessible for everyone whenever needed and without risk of financial hardship. Dear colleagues, time is now to address these inequalities in healthcare for all vulnerable groups, including people deprived of their liberty. And if we are talking about the achieving universal health coverage, this will not be possible if we leave people in detention behind. I wish you all a great session and of course, results in implementation at the country level. Thank you so much.
Thank you very much, Dr. Berzulli, for giving us the frame. I give the floor now to Olivia Rope. She's the Executive Director of Penal Reform International.
Thank you, Luciana, and welcome to all of you who are joining today from PRI. Thanks also to our partners at the WHO Europe's Health and Prisons Programme, and of course also UNODC. I will keep this short as I know that our panel has a lot to cover. But I wanted to start by saying that I believe this Crime Commission presents not only an opportunity to take stock and share the positive and also the negative impacts that COVID-19 has had on prisons and also wider criminal justice systems, but also an opportunity to address the underlying issues and the crisis that prisons were in globally when the pandemic first hit a little over a year ago. And I'm speaking specifically about the overcrowding rates and the overuse of imprisonment that we see in most regions that has led to a record high in the global prison population today. And in this regard, I want to highlight commitments that have been made by member states in the UN Kyoto Declaration at the Crime Congress in March that the Commission should take forward as a priority. And these recognise the impacts on prison conditions and including health, that there needs to be a commitment to addressing overcrowding through the use of alternatives to pretrial detention and also custodial sentences. This is well overdue. This is not a new issue. And in our latest edition of our flagship annual publication, Global Prison Trends 2021, which we co-published with the Thailand Institute of Justice last week, we detail the impact that COVID has had on prisons in view of these long-standing issues like underfunding and overburdened prison facilities. I'll leave my colleague Trina to give you more detail on these findings that we have in our report. And thank you, Luciana. I look forward to the discussion today.
Thank you, Olivia. I give the floor now to Mr. Andres Fingerud. He's the Chief of the Drug Prevention and Health Branch of the United Nations Office on Drugs and Crime. Mr. Fingerud, you have the floor.
Thank you, Luciana. Thank you for giving me the opportunity to speak at this side event of the 30th Commission on Crime Commission. And I'm following up on two introductions, so I might cover some of the territory, but let me just have a few words. There's currently around 11 million people in prisons or other closed settings at any given time. The vast majority of whom will return to their community, often within less than 1 year. The health of people in prisons and closed settings matters, and their health and well-being is also directly relevant and linked to the health and well-being of the community and the general population. While some countries have been able to implement comprehensive COVID-19 vaccination programs aimed at inoculating the general population as part of efforts to overcome the pandemic, in many countries, people in prisons are often not part of the vaccination drives. This can cause significant gap in vaccination coverage that may allow COVID-19 to continue to spread, delay the end of the pandemic, and have serious health consequences for the people living and working in closed settings and for the community at large. I mean, this point was already made about the need to ensure that vaccination programs in prisons are included in the national programs. People living in prisons and other closed settings are particularly vulnerable to infectious diseases, such as HIV/AIDS, tuberculosis, viral hepatitis, and of course, COVID-19. The prison and closed setting environments are highly conducive to the spread of infectious diseases. This is because of specific conditions and risk factors that affect many prisons, including, as already mentioned, overcrowding, but also issues of poor ventilation, poor or inadequate health facilities, and coverage and access to safe water, sanitation, and hygiene. Overcrowding is a particularly common problem. It is estimated that 115 countries have prison systems that are currently above capacity, many of which greatly above capacity. Furthermore, many prisons have sanitary and health and care facilities that are inadequate to handle the special requirements for controlling COVID-19. Hence, people in prisons have been and continue to be disproportionately affected by the ongoing pandemic. The pandemic has also exacerbated the ongoing HIV/AIDS epidemic. HIV prevalence among people in prisons is 7 times as high as that among the general population. In some countries, even 15 to 20 times as high. People living with HIV are even more vulnerable to COVID-19 due to pre-existing conditions such as weakened immune systems or other present infections. And the outcome of COVID-19 among them tends to be much more serious. Priority for early vaccination is usually given to those in the community who are especially vulnerable to severe outcomes. This should be no different for those living in prisons. According to the international standards, such as the United Nations Mandela Rules for short, people in prison should enjoy the same standard of health care that is available in the community. Apart from extending the benefit of treatment, whether for HIV, tuberculosis, viral hepatitis, or COVID-19 to people in prisons and other closed settings, it is equally important to ensure continuity of care for treatments started during or before incarceration, such as antiretroviral therapy, tuberculosis, and hepatitis. The same would apply for those people who are fortunate enough to receive a COVID vaccination while in prison and then receive their second shot while once back in the community. Since the beginning of the pandemic, UNODC has been supporting countries in their efforts to prevent and control the spread of infection in prisons, including delivering PPE and other medical equipment to prisons in countries with insufficient medical supply, but this alone is not enough. Timely and thorough vaccination is vital to bring the pandemic under control in all parts of society. We should also not neglect other current health crises that affect prison population, as already mentioned, tuberculosis, HIV. HIV and tuberculosis are still among the leading causes of death in prisons. Solutions to overcome the threat of COVID-19 in prisons and other closed settings should be seen as an opportunity to address ongoing issues that hinder progress in ending the threat of HIV, AIDS, tuberculosis, and viral hepatitis in prison settings, and bring us closer to the HIV target set in the UNA strategy for 2030. With this, I'll wish you success and look forward to the discussions that we will have in the course of this side event. Thank you very much.
Thank you very much, Mr. Timberu. We will start now with our speakers. After these three opening remarks who set the frame of the discussions, we will start with Trona Lenihan from Penal Reform International. She will give us a view on the background and context of places of detentions through the Global Prison Trends Report 2021 just launched. Thank you. You have the floor, Trina.
Sorry, I'm just trying to unmute. Oh, yeah. Can you see the presentation, Luciana?
Yes.
Great. So it's a pleasure to be with you all today and share some of the key messages and learning from Global Prison Trends 2021, which Olivia mentioned. I know the time is limited, so I'll try to be brief and encourage you all to read the full report when you can. The executive summary is also available in English and Spanish, and we'll have more languages coming soon, including Russian and French. So as we've heard, the global prison population continues to rise, and in the report we found that there continue to be significant variances in the use of imprisonment across regions and countries. This is largely due to a number of key drivers for high imprisonment and overcrowding rates. Some of these have remained relatively stable over the past years, including drug policies, particularly resulting in high imprisonment rates in Asia and the Americas, which between them house 3/4 of the global prison population. Also the overuse of pretrial detention and mandatory sentencing, as well as sentences getting longer and an increase in the use of very long and life imprisonment. This year in particular, we've also seen new offences for breaching COVID-19 regulations, which have resulted in a variety of sanctions, ranging from fines to short prison terms in some places, and even longer prison terms in some countries. We've seen up to 3 years allowed in Uzbekistan and up to 20 years in Cambodia as of March this year. So as we've heard already, this has been leading to chronic levels of overcrowding in some places. And in the context of the pandemic, that overcrowding has really exacerbated the poor conditions in prisons in many countries, particularly around access to healthcare, hygiene and nutrition, which is really putting the lives of people at particular risk. Some countries did reduce overcrowding, particularly in the earlier part of last year through a combination of both the reduced court processes during restrictions in the community and also emergency release mechanisms, particularly during the first peak. But overall, it hasn't really made a significant or lasting dent in the global prison population. It's due to a number of barriers implementing the schemes, which are analysed in the report, And we're also now seeing increases again in prison populations as work is done to clear a lot of the court backlogs, which built up when proceedings were suspended last year. On a positive note, we did see an increase in alternatives to the use of imprisonment in response to the pandemic, but the impact of that has varied significantly between countries. Within prisons, people have been and still are especially vulnerable to COVID-19, largely because of the living conditions, cramped spaces, lack of hygiene supplies, and poorer health status compared to the general population. And as we've heard already, the pandemic really sort of exposed existing failures or difficulties in prison systems to meet even the most basic standards of healthcare in some places. So the true human cost globally in prisons is still unknown. These figures are really limited by what's publicly available, but there are a lot of ongoing data collection and transparency issues which are outlined in the report. And this means that the true number will be much higher. We've seen significant differences between countries in the availability of testing and other measures to prevent transmission in prisons, which are documented in the report. And this has meant that some countries have done a lot better than others in preventing or containing outbreaks in prisons. But what we found is even where prisons have managed to contain outbreaks or done well in reducing transmission, the measures that have been put in place in order to achieve that, in some places which are in place for over a year now, have really increased isolation and had a significant impact on the people detained. Particularly in prisons with cell-based infrastructure, we've seen entire prison populations or segments living in effective solitary confinement for up to a year, which goes against international standards, which limit its use to 15 consecutive days. And this is having a huge impact, particularly on mental health. We've documented in previous editions of the Global Prison Trends report the sort of growing crisis in mental health in some prison systems. And now with the additional restrictions over the past year, this is really reaching worrying new levels. And we're already seeing some data coming through showing increases in self-harm and suicide rates in some prison systems. So like at the community, really, a very important aspect of the responses is around vaccines and the potential of vaccines to allow us to ease many of the restrictions that have been having such a negative effect in prisons over the past year. We've found that at least 13 countries have prioritized prisons in their vaccination strategies, and another 11 countries have included but not prioritized prisons. But many other countries have not specifically referred to prisons at all in their vaccination strategies, which is worrying. And this is important really for people that are detained, but also working in prisons. Prison staff have endured significant changes in their workloads and conditions over the past year. In some places, living or being locked down on site for significant periods of time, and also faced an increased risk of contracting the virus. Some countries have classified prison staff as essential workers, but overall their situation hasn't received adequate attention from decision makers. And we've found a huge range globally in staff to prisoner ratios from about 1:1 to about 1:28 in some places, with more staff shortages reported over the last year because of illness or the need for staff to isolate or changes in ways of working and organizational structure during the pandemic. So this highlights again the need to ensure that prison staff are prioritized, including in measures like vaccine rollout. Finally, just to mention, the special focus of this year's report looks at prisons in crisis, that includes health crisis, and where we've learned from previous crises in prisons, including Ebola or outbreaks of cholera, Also how countries and prison systems rebuild after conflict or disaster, and looking at the use of prison labor in times of crisis as well, and the contribution of prison populations in national responses, which we've seen again over the past year. So there's lots more detail in the report, and I'll invite you to read it in full or use it as a reference in your work. And I'll look forward to hearing from the other speakers. Thank you.
Thank you, Triona, for your comprehensive exposition. That was very helpful and informative. Now we will go to Dr. Ehab Salah from the United Nations Office on Drugs and Crime, and he will talk to us about how to address infectious diseases in places of detention. Will walk us through an updated, comprehensive package of interventions. Dr. Salah, you have the floor.
Thank you very much, Luciana, and I'm happy to be here with you today. And thanks for colleagues from WHO and PRI. Always a pleasure to work with you. And I think the opportunity to have this important side event is presenting itself through the big number of the participants we have right now, which is, I can see from my screen, we got more than 160 participants, which is really reflecting that this topic is relevant to the audience and it's very much needed to bridge the gaps at the country level. It's always a pleasure to work with you, and the opportunity we have today talking about the report and the technical guide on prioritization of people in prison, the national vaccination plan. This is very important, and this is not the first time. We work together on similar publications. We have many. Of course, you will remember our flagship publication on health in prison, and also the good governance of health in prison settings as well. So this is like a continuation of a good collaboration between UNODC and other relevant organizations in this specific regard. And unfortunately, we are not many who are like talking about health in prison. Anyway, so my talk today, I'll focus more on the health and infectious diseases in prison settings, including, of course, COVID-19, HIV, viral hepatitis, TB, and other infections in prison settings. But first, we need to know where we are when it comes to the transmission, the high transmission of HIV and other infections in prison. So this is a summary, I'm sure you're aware of this. This is a combination of data that has been collected in 2016 and 2019. And here for HIV, as Andres mentioned in his opening remarks, we have like 4.8% of people in prison. They are living with HIV, 15 living with HCV. TB, active TB is 2.8%. And COVID-19, we are not sure. We're still receiving data from countries. We don't have concrete data, but however, anecdotal data we are receiving from the countries right now about the number of people living and working in prison setting is definitely indicating that prison population are much, much higher when it comes to the prevalence and the vulnerability as well. And this is a concern when we talk about COVID-19 in prison. And at the beginning of 2020, when COVID-19 started to hit the world, there was a big challenge in many, many countries all over the world for many, many obvious reasons, of course. So for this reason why prisons are a place where the prevalence of infectious diseases are much higher, for obvious reasons, of course, the overcrowding. One of the major prevention measures for COVID-19 is the physical distance, which is not an option in many prisons all over the world. Majority of the prisons are overcrowded. We all know that. Also, the key population, vulnerable population, the health profile of people in prison. Many of people in prison are coming from a deprived population, and this means that in order to reach the equitable level of health, we need to do more and more. Not speaking about the prison condition, the living condition, the availability of services, isolation from public health. And also I go back again and speak about the COVID-19, where when we start putting together the national plans for COVID-19 response, and prisons were not there in many countries. And it took us a long time to make sure that prisons are integrated within the national plans for COVID-19 to ensure that resources are there, including all the PPE measures or the testing kits, and also the staff to work on addressing COVID-19 among this very important vulnerable population in prison settings as well. So this is many reasons why infectious diseases are much higher or higher prevalence in prison settings as well. And when we talk about COVID-19, this is like bringing to our attention the long-standing calls for the United Nations, starting from addressing or reducing overcrowding or alternative to imprisonment, and all these long-standing calls that the United Nations has been calling a long time ago. But COVID-19 came to bring it back to our attention and put it at the center of our attention that we need to work on this, including the principle of equivalence as emphasized in the Nelson Mandela rules, the United Nations standard minimum rules for the treatment of prisoners, as well as when we talk about the medical ethics and respecting the human rights of people who are in prison settings, indicating that we need to respect the voluntary services, confidentiality of people living in prison settings as well. We started working on the addressing COVID-19 in prison very early through infographics, technical guidance, also with WHO HIPP, Health in Prison Program. We have the position paper for the United Nations. We did it with many relevant UN agencies, and the joint statement that has been issued by the principals of many of the principals or the heads of many UN agencies, including UNODC, OCHA, WHO, and others as well. Now we talk about the comprehensive package, and this is the comprehensive package for HIV and other infections in prison that has been launched for the first time in 2013, but we found that this is the time to update it. And now we manage with other 5 UN agencies like WHO, UNFPA, UNDP, ILO, VMS, UNAIDS, of course. We managed to revise the comprehensive package for HIV testing, treatment, care, and support in prisons and other closed settings. It's now available in English on our website, and we are in the process of translating it to other languages as well. But it's not only addressing HIV, it's addressing many health-related topics, including viral hepatitis, tuberculosis, as well as COVID-19 and other man-made disasters, natural disasters as well. And also it encouraged the prison authority and other relevant authorities to be prepared for addressing any other health crisis, because COVID-19 is happening now, but we believe that this is not the end, and we might be hit by another health disasters in the coming, hopefully not, but it may, if it happens, we need to be prepared for addressing this as well. So what we need to do together, and where the gaps, where the areas we need to work on is, number one, we need to improve our data collection, monitoring, and evaluation system. We need to know more data to be collected at regular basis with feedback and to be shared with the central level with health information system. Still, in many countries all over the world, data and strategic information is a big gap. We encourage the engagement of people in prison in the development and implementation of the programs, and to inform them. We need to talk to them. People living in prison, they have the right to know. Remember, at the beginning of COVID-19, there are many riots in prison. And the main reason is because you don't know. And you don't know what's happening. They don't have access to internet. They know that there is a pandemic that's killing people and they are at risk. And people died because of the riots, not because of the COVID-19. Again and again, addressing prison overcrowding comes on the top of the agenda for our work, and it should be for many counterparts at the country levels as well. And now we need to focus again on reducing prison overcrowding, which the majority of countries all over the world are suffering from. This should be including the promotion of alternative to imprisonment, alternative to conviction or punishment for minor drug-related offenses, promoting non-custodial measures as well, and also the compassionate early release for specific categories of people in prison, or temporary suspension of sentences. All this like many countries are adopting many of these measures. It depends on the country context, but all will lead to reducing prison overcrowding as well. Again, we talk about the promoting the international standards, including the Nelson Mandela rules and the Bangkok rules, which is promoting non-custodial measures for women offenders as well. Health in prison is not part of the punishment, and we also promote that infectious diseases or health in general should be integrated in the national plan. And this is one of the topics we insist and we call upon it many times before. And let's not forget the gender responsive initiative. Women might be representing only 7% of the prison population, but their needs are missed in many countries all over the world. And engagement of civil society and community-based organization for many reasons, like including security or safety reason. Civil society organization, they are not engaged in the prison health work. And we, as people working on this area, we need to build the capacity of civil society organization to work on this. And final thing I want to share with you here is ensuring sustainability and continuity of care. Because when COVID-19 started, it became like a shifting priority, and many of the services has been disconnected or interrupted. So we need to ensure that we have a mechanism in place that will allow for the uninterrupted services in prison, when transferred from prison to another, and on release to the community. I leave it here. Thank you very much, and I wish you all the best. Thanks, and back to the moderator. Thank you very much.
Thank you, Dr. Salah, for your exposition, for pointing out the urgent need to improve data collection and also, of course, the reduction of overcrowding. We will go now to our next speaker, Dr. Filipa Alves da Costa. She's a consultant for WHO Regional Office for Europe, and she will give us an overview on vaccination against COVID-19 in detention settings, addressing the question of why people living and working in detention facilities should be included in COVID-19 vaccination plans. Dr. Alves da Costa, you have the floor.
Thank you very much. So it's a pleasure to be here today and share with you the announcement of this advocacy brief that we're about to launch, which is entitled Vaccination Against COVID-19 in Detention Settings. And it's explaining why people living and working in prisons should be included in national vaccination plans. So the reason why we thought it was important to develop this advocacy brief was because we have been monitoring the emergency of outbreaks in prisons in the European region. And whenever there have been situations of outbreaks, we have developed virtual missions to support member states in defining or realigning their response strategies. In some of these meetings, we have had expressed needs for additional support in the assurance that ministries of health will indeed include prisons in the national vaccination plans. So we thought this advocacy brief could be a way to answer two key questions, which you can see on the slide. So what are the key considerations for including the prison population in national vaccination plans? And what are the underlying principles guiding these considerations? So we have developed a four-stage methodology. We first started with developing a rapid literature review. This was led by WHO HIPP, and we have included not only reports from the scientific literature, but also media reports, following which we had input from external stakeholders with whom we worked as partners, namely PRI and UNODC. We then issued a call to member states in the European region, asking for their national vaccination plans and for them to specifically refer to the inclusion of prisons in these plans. Then UNODC and PRI also did the same, but expanding the scope beyond the European region to ensure that a global outreach was represented. In the final stage, we have then included contributions from other WHO divisions to make sure that the recommendations included are aligned with WHO policy. So we have contributions namely from the Division of Vaccine Preventable Disease, from the Health Emergency Program, and also from the Division for HIV, AIDS, Hepatitis, and other infectious diseases. So as vaccines became approved, we have been seeing and happily that the inclusion of vulnerable and at high risk groups have been achieved in national deployment and vaccination plans. However, more needs to be done because the prioritizing of older populations seems to be consensual, but it's not exactly uncontroversial, the inclusion of people living and working in detention facilities. And this is despite ample evidence that prison populations have experienced COVID-19 outbreaks and that they are particularly vulnerable to SARS-CoV-2. And this is, of course, a consequence of various aspects that have already been highlighted by previous speakers, namely the environmental conditions, which include overcrowding, but not only, also the inequalities in health status, and finally, and also very important, the unequal healthcare services that in many countries still tend to be inferior to those that are available in the outside community. So for all these reasons, we have issued some considerations and call for member states to consider them when developing and adapting their national vaccination plans. The first one is the inclusion of prison populations as communities that are unable to take appropriate public health measures to prevent infections. And this includes, of course, physical distancing, but also hygiene. It has been highlighted that there are still many countries that have limited access to water and hand washing facilities, of course, also to PPE, but also there's limited testing capacity in prisons compared to the outside community. There's also the fact that congregate living itself and dormitory housing are well recognized risk factors for acquiring SARS-CoV-2 infection. The second consideration refers to older people living in prisons, and there are recommendations that are being implemented worldwide that the older people should be prioritized. However, the specific age bands that are implemented at the country level are adapted according to the circumstances of member states. And in this advocacy brief, what we highlight above all is the fact that we cannot have a direct equivalence between the age of people living out in the outside community and people living in prisons. We know that there's a worse health status, and we know that the prison itself has an aging effect. So unless the vaccination plans are adapted, we will miss the true elders that live in prison. The second aspect that we call for is the inclusion of people that live with underlying conditions, above all with NCDs. And because we know that there are still severe deficiencies in the health information systems that exist in prisons. So it is essential to adequately capture the people that are living with NCDs and make sure they are included in the national vaccination plans. Then we call for the inclusion of prison staff and healthcare staff, and I'm glad to see that there's also some talk about this in the chat, where we can see the disparity of the plans that are being implemented. Some colleagues are happy with the way things have been evolving in their countries, where others specifically state that it's still suboptimal. So the main aspects to highlight here is one, that detention facilities in several countries still face issues of limited supply of PPE, and this is not only for the prison population, but also for the healthcare workers. So this means that outbreaks of COVID infections among prison staff have been observed in many European countries, of course, and beyond, but our data is from Europe, and some of them, in some of them, the cases represent up to 85% of all cases. So it is crucial that prison staff are included in national vaccination strategies. Our final points call for the inclusion of prisons because of the high risk of transmission into the community and because of the social vulnerability of people that live in prisons. So we know that each year more than 30 million people go in and out of prisons on a global scale, and these numbers do not account for the personnel, so the staff that moves in and out on a daily basis. And contrary to the popular belief, most prison stays are relatively short. So we're talking about months rather than years. And this in fact means that prisons can never be completely isolated from surrounding communities. So if we fail to protect those that are living in prisons, we will put communities at risk of further spread of this infectious disease. So as to finalize, then I call for the 4 principles we have identified as crucial. One is the right to healthcare, which is well established in the Nelson Mandela rules, which have already also been referred to, where it is mentioned very clearly that the provision of healthcare for prisoners is a state responsibility. And this means that the right to healthcare is a human right that applies to every citizen, and this is despite of their legal status. The second one is the principle of equivalence, which states that people in prisons should enjoy exactly the same standards of healthcare that are available to the outside community. The third one is universal health coverage, and Dr. Berzulli already referred to this in the opening remarks as one of the core priorities of the GPW 13, where it is clearly stated that no one should be left behind. And the targets set cannot be met if people living in prison are excluded from vaccination rollouts. So the final one is continuity of care. We know that prison is a transitional setting, and we need to ensure there's good governance in place and coordinated response between public health services and the ministries that are responsible for health in prisons, and this is imperative. So as key messages, we are very strong.
Doctor, just if you can wrap up in less than 30 seconds.
Sure, it's my final slide. So the evidence is very clear that people that live and work in prison are at higher risk, and our key message is that people should be included in national vaccination plans. Ideally, we should have facility-wide vaccination, but if that is not possible, we call at least for the prioritization of vulnerable groups and the inclusion of health and care workers as a person as at higher risk. So thank you.
Thank you very much for your exposition, and certainly most of our countries have faced this controversy to include these groups in the prioritization. So thank you for giving us those reasons. We will go to our last speaker. We will be going a little over time, but we ask our last speaker to keep under 10 minutes then, so we can conclude in reasonable time. He's Dr. Tawfiq Abtal. He's the Chief of Health Division at the General Delegation for Prison Administrations in Morocco. And he will tell us a bit about the challenges and opportunities for implementing COVID-19 vaccinations in detention facilities in his country. Dr. Abtal, you have the floor.
Thank you. To overcome the language barrier, hi, I'm Lubna, and to overcome the language barrier and share with you the experience of Morocco, I will present on behalf of Dr. Abtal. But first, Dr. Abtal would like to say a few words in Arabic that I will translate. Thank you.
السلام عليكم. في البداية أتقدم بالشكر لجميع المنظمات التي سارت على تنظيم هذا اللقاء على هامش اللقاء المنعقد على عقدته دورة لجنة الأمم المتحدة للوقاية من الجريمة والعدالة الاجتماعية حول المجهودات المبذولة من طرف المندوبية العامة لإدارة السجون في مجال التصدي لفيروس كورونا بالسجون. وستقوم السيدة لبنى بنوة بتقديم عرض جد مختزل نظرا لضيق الوقت لتوضيح ما قامت به المندوبية العامة لإدارة السجون للتصدي لهذا الفيروس بما في ذلك الحملات التلقيح. وتحياتي من الرباط. شكرا جزيلا.
So Dr. Abtal said greetings from Rabat, and he would like to thank the regional WHO Office for Europe and also PRI and UNODC for the invitation of the Kingdom of Morocco on this side event and to take part and to share with you the experience of the General Delegation for Prison Administration and Integration on the COVID response.
Thank you very much. We will have to wrap up the event at 20:10. So I beg you as far as possible to have that in mind in the exposition. Thank you.
So the vaccination is one of the measures of the COVID-19 response in Morocco. So it was necessary for us to present the main measures adopted by the Kingdom of Morocco. These measures were integrated, harmonized, and multidisciplinary, affecting all aspects of prison management. Here is a quick overview on the COVID-19 developments in prisons. Since 11 February, the DGAPR has installed monitoring units in its headquarters for the preparedness and control of COVID-19 spreads in prison. The response is dynamic and adapt to the evaluation of the situation. Hence, the importance of the monitoring cells at all levels of management that allow a quick and prompt adaptation of the response. The measure taken delayed the appearance of the epidemic in prisons, an interval of 14 days between the appearance of the first case and in the general population and the first case in prisons. Here are some measures, main measures of the response to COVID-19 in prisons. The first pillar was to strengthen the health security measures. All prison staff were involved in the management of the crisis. The medical staff was trained and awareness raising sessions were delivered to prisoners and prison staff for the introduction of barrier measures and increased vigilance on the admission and the systematic medical exam on admission. Despite the situation, inmates benefited from the continuity of healthcare services. We have to highlight that more than 18,000 HIV tests has been delivered this year and 5,000 TB screening in the first half of 2021. The DGAPR also has assured the continuity of the OSC program and tried as much as possible to reduce the prison population. Royal Grace benefited to more than 5,000 inmates, and also the reduction of interaction with the outside world, with the suspension of interfacility transfers, the reorganization of work in 3 periods. All prison staff were confined for 15 days in prisons. Before the declaration of the first positive case in prison, the judicial transfers were reduced, then suspended and replaced by remote hearing. Family visits, unfortunately, have been reduced, then suspended. At the same time, more phone calls were allowed, and the allowance of prisoners has been increased. Here's some specific measures. In addition to the general measures, specific arrangements has been made for the management of suspected cases on the admission of new entrants. Also, it was important to mitigate the effects of the confinement. The DGAPR has reorganized the educational and occupational training programs in compliance with physical distancing and barrier measures. Within the framework of occupational training, the DGAPR set up a program of production of masks in line with the international standards. More than 22,000 units were produced per day, and it constitutes the stock of masks of the DGAPR. All these measures will not be possible to be put in place without proper logistics and resources. We have to highlight that the DGAPR has reallocated its budget and prioritization and setting up the necessary logistical means, provision of sufficient food stock, and also provision of PPEs, and also the DGAPR has had benefited from the support from its partner, from international organization or government partners. One of the pillars of the response is the communication. It was participatory and also regular, daily and weekly press releases, information sessions for the inmates, awareness raising activities, and also the inmates were requested to relay the information to their families. These measures, no incidents of mutinies have been reported since the restrictive measures, and also this communication was necessary for the prisoners' families. For the vaccination campaign, the vaccination campaign in Morocco was launched on January 28th by His Majesty the King Mohammed VI. And in accordance with the High Royal instructions, the vaccination is free for all citizens. The campaign, which is taking place gradually, will benefit all Moroccan citizens and foreigners living in the kingdom over 18 years. The vaccination campaign started in the first phase in 29 of January. All employees of the DGAPR are now vaccinated. In the 2nd March, the vaccination campaign started for prisoners. According to age group, in line with the national vaccination strategy adopted by the Ministry of Health. For now, 1,300 prisoners are vaccinated with the 2nd dose. We have to note here that 80% of the prison population is less than 40 years. That's why the figures are low. The operational procedures for managing the vaccination campaign in prison. At the beginning, the health unit in prison were integrated with the vaccination stations established by the Ministry of Health. they were equipped and provided with logistical resource. Training of medical and paramedical staff were delivered, and the vaccination is assured by the medical prison staff, and with an oversight and a supervision from the Ministry of Health. Also, the DGAPR ensured the second dose of the vaccine for released prisoners, and an ongoing coordination between the health centers of the Ministry of Health and the prison is ensured. The vaccination process. First of all, the vaccine is administered on a voluntary basis. After each dose of the vaccine, the prisoner will be briefed by a healthcare professional who explains the need to comply with barrier measures and physical distancing while waiting for the vaccine to become effective, the possibility of the occurrence of adverse reactions and how to manage them, and of course the need to report any adverse events to prison staff.
I'm very sorry. Hello, I'm very sorry to interrupt you. If you could wrap up in around 30 seconds, I appreciate it. Thank you.
Here are some figures on the COVID epidemiological situation in prisons in Morocco, and some indicators. And we would like to finish with a draw of a prisoner, and thank you.
Thank you very much for sharing your experience and information on Morocco, and thank you for making available for all the attendants. I thank all the participants. We need to wrap up now because of the tight schedule we had. We had a very impressive exchange in the chat, so we appreciate all your comments and your contributions, and speakers will be happy to follow up with you after this event. I want finally to thank all the speakers for sharing their experience, their materials, and we will make sure to circulate all of them in the chat. So have a good day, everybody, and thank you for attending this event.
Thank you.
Thank you very much. Bye-bye.
Thank you very much, everyone.